Good evening. It's our pleasure to start the second session of the Heart Failure Summit 2020. It is my pleasure to introduce Professor Mark Petrie, Professor of Cardiology, University of Glasgow, Honorary Consultant Cardiologist, Glasgow Royal Infirmary. Huh? It's not.
Thanks very much. I'm just checking. Can you see my slides?
You are. Excuse me, Mark. You are mute.
Muted.
Mark.
You hear us?
I can hear you clearly. Yeah.
Please unmute. The sound is not here.
I can hear you clearly.
We cannot hear you.
Yeah, I am unmuted, so I don't know why that is.
Okay.
Yes.
Yes, we can hear.
You can hear me now?
Yes, we hear you good. Okay.
It's
Okay,
our
fantastic.
pleasure to be with us, and we will talk about the SGLT2 inhibitors, a new era for heart failure care. Please, Professor Mark Petrie.
Great. Thank you again for the invitation to speak. It's a true honor. And it's also a privilege to talk about SGLT2 inhibitors because I think they really have made a major change to the management of patients with heart failure. So what I wanted to do was begin with talking about why we need new treatments for heart failure with reduced ejection fraction. Perhaps some interventional cardiologists or some people involved in cardiology don't realize why we need new treatments. But if you look at people in the clinical trials, including sacubitril/valsartan or Entresto, also on beta blockers and mineralocorticoid receptor antagonists, we see that they still have a very high risk of dying or being hospitalized for heart failure. And in the PARADIGM-HF trial, people on sacubitril/valsartan had a 1 in 4 chance of dying or being hospitalized over 2 years. So these people with heart failure, despite good treatment, are at high risk of cardiovascular events. So the first trial I want to talk about is DAPA-HF. And DAPA-HF was the trial looking to treat heart failure with reduced ejection fraction with dapagliflozin. This is a very simple trial. It included patients with heart failure with a reduced ejection fraction below or equal to 40%. People in DAPA-HF had to have end-terminal proBNPs of over 600 picograms per mil. There were very few exclusion criteria, people with eGFRs less than 30 or systolic blood pressures less than 95 or type 1 diabetes. The primary endpoint was the usual primary endpoint of clinical trials of cardiovascular death or heart failure hospitalization, with the addition of urgent heart failure visits, which means coming up and seeing your heart failure clinician and receiving intravenous diuretics. So DAPA-HF was probably the simplest trial yet performed in the field of heart failure. We had no run-in period and no titration steps that we're used to with drugs like beta blockers or ACE inhibitors. There was a simple randomization to placebo or 10 milligrams of dapagliflozin once a day. The patients were seen in the trial after 2 weeks and then 2 months and 4 months, and then every 4 months through the trial for monitoring purposes. So who were the patients in DAPA-HF? Well, these patients were people that you and I see every day in clinical practice. They were mean age of 66. Most were men. 2/3 had New York Class Association 2 heart failure and 1/3 Class 3. Their mean ejection fractions were 31% and their end-terminal proBNPs were just below 1,500. Interestingly, half of the patients had an ischemic etiology and half of the patients had a non-ischemic etiology. Probably the most important thing about this slide is that the majority of patients in DAPA-HF did not have diabetes. So 55% without diabetes and 45% with diabetes. So some people still think of these drugs as diabetic drugs, but this is definitely not a diabetic drug. It's a heart failure trial and a heart failure drug in patients with and without diabetes. So this is a primary outcome slide that was presented at the ESC in 2019. And you can see here the 26% reduction in the primary outcome of cardiovascular death, heart failure hospitalisation, and urgent heart failure visit. And you'll notice the absolute benefit with the numbers needed to treat of 21. It's also important to have a look at these curves and see how quickly these curves separate. We see within weeks that dapagliflozin is better than placebo in terms of preventing cardiovascular death or heart failure hospitalisation. So when we look at a primary outcome in a trial, we always want to look at the components of the primary outcome, if there are two of them. And we can see here that both components of the primary outcome were reduced. Worsening heart failure event was reduced by 30% and cardiovascular death by 18%. Normally in clinical trials, when we have a primary outcome, we use a time to first event analysis. So we only count the first hospitalization or the first death that happens to patients. This is an analysis looking at all of the hospitalizations that happen over the course of the trial, which is of course important to patients, as patients they're not just concerned about one hospitalization, but if they have 2, 3, 4, or 5 hospitalizations, that's also important to them. As you can see here, we saw a 25% reduction in total heart failure hospitalizations and cardiovascular death. When I see patients in clinic, their most common request is that they want to feel better rather than live longer or stay out of hospital. So this analysis of quality of life is incredibly important. This is measured in heart failure trials by the Kansas City Cardiomyopathy Questionnaire. And when we look at the Kansas City Cardiomyopathy Questionnaire, it's really an excellent questionnaire. It captures many things, such as the symptom burden of the patients, the functional and social limitations, as well as quality of life measures. And when we looked at dapagliflozin and DAPA-HF, we saw really marked improvements in quality of life. Whenever we talk about improved quality of life by the Kansas City Cardiomyopathy Questionnaire, we usually have a threshold of greater than a 5-point improvement as a clinically meaningful improvement in quality of life. But actually in DAPA-HF, we saw much greater improvements than the minimal threshold, which is usually used in trials. And as well as improving quality of life in DAPA-HF, we also saw fewer patients deteriorating, which is also very important. To prevent deterioration in heart failure is as important as improving quality of life. When we think about how many patients we have to treat to improve quality of life, this is really quite impressive, with numbers needed to treat as low as 12 to 17. So when we think about SGLT2 inhibitors, there's been some confusion about EGFR and creatinine and SGLT2 inhibitors. And in many of the licenses, these drugs were not used in people with low EGFRs. That was nothing to do with safety or cardiovascular benefit or lack of it. The reason people didn't use these drugs in people with low EGFRs was because the glucose lowering effect of these drugs lessens as EGFR goes down. So we know clearly these drugs are beneficial for the kidneys, having seen the results of the diabetic trials and also now the chronic kidney disease trials. So this is a very simple graph looking at how many patients in DAPA-HF had a doubling of serum creatinine on dapagliflozin or placebo. You can see fewer patients taking dapagliflozin than placebo had a doubling of serum creatinine, and in fact, just about halved the risk of doubling serum creatinine. And this is to emphasize, when we look at the primary outcome, that patients with an EGFR above or below 60 had exactly the same benefit in terms of reduction in cardiovascular death or heart failure event. So again, we need to really try and remember there is no safety concern with EGFRs less than 60, and we see the cardiovascular benefit in these patients with low EGFRs. So whenever we have a clinical trial in heart failure which reduces cardiovascular death, we want to also look at all-cause death, and we hope we're successful enough to reduce all-cause as well as cardiovascular death. We were delighted to see that all-cause mortality was reduced in DAPA-HF by 17%. So safety is as important for clinicians looking after patients as efficacy. And when we started DAPA-HF, we weren't confident that we wouldn't have an excess of safety events. we were introducing a drug with some diuretic properties on top of a loop diuretic and a mineralocorticoid receptor antagonist and sacubitril/valsartan in some cases. But we were pleased to see there was no excessive volume depletion events. This is things like dizziness or hypotension or renal adverse events. And again, from a cardiology perspective, if we're using a drug that used to be thought of as a diabetic drug, we didn't see any excess in major hypoglycemia. We did see 3 cases in the whole trial, so 4,700 patients with lots of hospitalizations over an 18 months mean follow-up. We saw 3 cases of DKA in patients with diabetes in this trial. So there is a very slight increase in DKA. This is very unusual. So now turning to the results in DAPA-HF in patients with and without diabetes. And again, remember, we used to think this drug was a diabetic drug, but we can see here that patients without diabetes had the same benefit in terms of reduction in cardiovascular death and heart failure event as people without diabetes. You notice here the patients with diabetes had a higher event rate, so died more often and had more hospitalizations, so the absolute benefit was slightly greater in patients with diabetes than patients without diabetes. So just to go into more detail with respect to this issue, this graph looks at HbA1c across the x-axis and hazard ratio across the y-axis. You can see here the hazard ratio was well below 1, favouring dapagliflozin, regardless of baseline HbA1c. So regardless if your baseline HbA1c is 6 or 8 or 10, we just say the same benefit. So this benefit is definitely not a glucose-lowering benefit and not related to glycemic status. So moving on now to age, whenever we have a heart failure therapy, we're keen to make sure people understand if it's safe and effective in older patients as well as younger patients. And we were able to do a pretty good analysis in DAPA-HF as we had over 1,100 patients aged over 75. This is the same kind of graph, age along this axis and the y-axis hazard ratio. You can see we saw consistent benefit of DAPA with respect to all outcomes, regardless of whether patients are 50, 60, 70 or 80. So consistent benefit across age groups. We're really keen to understand from DAPA-HF if DAPA had benefit over and above different baseline or background heart failure therapies. And we've really performed extensive analysis looking at this issue. So we've looked at the benefit of DAPA on top of full dose of all pharmacological and device therapies down to very low amounts of therapy. So whether that's MRA or RNA or ivabradine. And indeed, our ACE inhibitor and beta blocker analysis were in people on large doses and small doses. And any way you look at the data, dapagliflozin was superior to placebo on top of any baseline heart failure therapy combination. So this is looking at the data with respect to whether or not patients were taking sacubitril/valsartan at baseline. And you can see here that dapagliflozin was better in terms of reducing cardiovascular death and heart failure events, regardless of whether people were taking sacubitril/valsartan at baseline. So 25% reduction in people taking RNAs or sacubitril/valsartan and 26% of people not taking these drugs at baseline. So really, we did see an incremental or additive benefit of DAPA over and above placebo. So now looking at EMPEROR-Reduced. So I'm sure you're aware that EMPEROR-Reduced was a sister trial to DAPA-HF, but using empagliflozin in heart failure with reduced ejection fraction instead of dapagliflozin in DAPA-HF. So just to focus on the differences between these trials, there were 1,000 fewer patients in EMPEROR-Reduced. They were followed for 2 months, a shorter duration of follow-up. There were some differences in the inclusion criteria. So you had to have a higher end-terminal proBNP in EMPEROR-Reduced, a slightly higher blood pressure at baseline, so over 100 was necessary for EMPEROR-Reduced against 95 for DAPA-HF. And people were included in EMPEROR-Reduced, the eGFRs down to 20 in EMPEROR-Reduced, as opposed to down to 30 in DAPA-HF. So these different inclusion criteria resulted in slightly different populations, with slightly lower eGFR in EMPEROR-Reduced at 62, slightly higher end-terminal proBNP, just under 2,000, lower ejection fractions at 27, and more sacubitril/valsartan, more ICDs, and more CRT. So despite these differences, we see very similar results for DAPA-HF and EMPEROR-Reduced. This is looking at the primary outcome of EMPEROR-Reduced, which is slightly different than DAPA-HF in cardiovascular death, hospitalization for heart failure, but not including urgent heart failure visits. But you can see here, we see a really very similar benefit with a hazard ratio of 0.75 to 25% relative risk reduction. You can see here the same effect as DAPA-HF with separation of the curves earlier. So again, similar results on total heart failure hospitalizations or first and recurrent events, really very similar 30% reduction in this endpoint, which is the same as we saw in DAPA-HF. So on the same day as EMPEROR-Reduced was presented this year, there was a meta-analysis in the Lancet, which showed again the similarities between these trials. We saw almost exactly the same effect on cardiovascular death or heart failure event. You'll remember we saw this mortality benefit in DAPA-HF, which wasn't seen as a standalone trial of EMPEROR-Reduced, but when the authors of this meta-analysis looked for a heterogeneity or a difference between these trials, they didn't find any. So turning now to Soloist. So Soloist was a trial just presented at the American Heart Association a few weeks ago. This is a very interesting trial of a drug that was not just an inhibitor of SGLT2, but also SGLT1. This trial was stopped early because the funding was withdrawn by the sponsor. And it was slightly different than the other trials. All of the patients in Soloist had type 2 diabetes, as opposed to EMPEROR-Reduced and DAPA-HF, which had with and without diabetes. All of the patients were hospitalized for worsening heart failure. So this is the first data in hospitalized patients, as opposed to DAPA-HF and EMPEROR-Reduced, which were ambulant outpatients. They also enrolled, interestingly, reduced and preserved ejection fraction patients. And again, they had a very similar primary endpoint of cardiovascular death or worsening heart failure event. So again, we see benefits of SGLT2, and in this case, one inhibition in heart failure. You can see here a 33% reduction in the primary endpoint, despite having quite small numbers of patients in the trial. And really interestingly here, in the very small subgroup of patients with ejection fractions above 50%, just over 256 patients, there did look like there's a benefit. But remember, this is an analysis of a small number of patients. So there's also a trial called SCORED, which is a trial of the same drug, sotagliflozin, in patients with chronic kidney disease presented. And the authors put all of the patients with heart failure and preserved ejection fraction in both trials together and found 739 patients. And again, there was a suggestion of benefit of these drugs in heart failure with preserved ejection fraction. I showed you these slides earlier, so just to say that next year we're going to have these two large trials of SGLT2 inhibition in HFrEF published, one with DAPA and one with one with empagliflozin, both around 6,000 patients. And again, hospitalized data, we've seen Soloist now, we've got two more hospitalized heart failure patient trials ongoing, a large one with empagliflozin and slightly smaller with empagliflozin. And I mentioned these two trials earlier on, the myocardial infarction trials with LVSD or heart failure, really interesting data in patients with and without diabetes. So these drugs are coming to every cardiologist very soon, not just heart failure cardiology. So the ESC guidelines 2016 encouraged a stepwise introduction of drugs, ACE inhibitors and beta blockers, and then MRAs, and then thinking about RNAs or CRT. And the question is where these drugs will fit into this algorithm. We were very impressed. The Indian Heart Journal published this 2 years ago now. And this was encouraging people to think about establishing people in all the major drugs for heart failure, not necessarily in a stepwise approach, but trying to get people on these drugs early. And they also drew attention to other very useful drugs in heart failure. So why might you want to move away from a stepwise or vertical approach and try and introduce the drugs earlier? Well, one's to improve outcomes, and I've shown you the early benefit. But also for efficiency, it takes less time to get people on the right drugs and less visits to hospital, which is particularly relevant in the COVID era. So to summarise, dapagliflozin and empagliflozin in heart failure with reduced ejection fraction, reduced cardiovascular death, heart failure hospitalizations, and improved quality of life. And that's regardless of diabetic status. We're looking forward to the guidelines, the ESC guideline update next year to see what they're going to say. And we're really excited about all the trials that we're going to see over the next 2 or 3 years. and just to urge you once again to take heart failure seriously and manage it carefully in heart failure teams and provide proper counselling, education and best management for our patients. So thank you very much for your attention.
Thank you, Professor Mark, for this presentation up to date. Actually, the group of SGLT2 inhibitors can be used to prevent heart failure, prevention of heart failure, based upon the three trials. DECLARE trial using dapagliflozin, CANVAS trial using canagliflozin, and the EMPEROR using empagliflozin. But in heart failure patient treatment, the DAPA heart failure, about 50% of patients were non-diabetic, and EMPEROR-Reduced heart failure trial, all the patients were in heart failure, not diabetic. But do you think, and this trial proved that the use of empagliflozin decreased the mortality by 25% in the EMPEROR-Reduced trial. Do you think that this group of drug will be the fourth group for the treatment of heart failure not diabetic? This is number one. Number two, still the guidelines, 2019 European guidelines, put the SGLT2 inhibitors class 2A in diabetic, not class 1, in diabetic. Still class 2A in diabetic. This is one question. The other question about the diuretic effect of SGLT2 inhibitors. There is a recent trial published in JACC mentioned that the combination of SGLT2 inhibitors with diuretic, after 3 weeks or 4 weeks, this group of drug lose its diuretic effect. What's your comment about this this point? And the first question about the use of this group of drugs in prevention and treatment of heart failure, whether diabetic or non-diabetic.
Yeah, so I think to deal with the questions one at a time, so prevention of heart failure, we've established a prevention of heart failure in diabetic trials. As you say, we have robust trials, all 4 of them in patients with diabetes. We have, though, now got data from the chronic kidney disease trials, and particularly DAPA-CKD in patients with and without diabetes, also showing reduction in heart failure hospitalization. So I think we do have some evidence for prevention in people without diabetes. But the majority of evidence for heart failure prevention is in diabetic trials. From a point of view of the guidelines, I'm not sure what the guidelines are going to say. I think they certainly will give they certainly should give a 1A recommendation for heart failure therapy with and without diabetes, because now we've got 2 large outcome trials. We've now got EMPEROR-Reduced and DAPA-HF, both of which showed benefit, and the meta-analysis confirms that in patients with and without diabetes. So I'm very sure a 1A recommendation will follow. The diuretic effect question is very interesting, and certainly I think we have to think about that closely. They certainly do have a diuretic effect to some extent, but that generally is seen to wear off after the first few weeks or first few months maximum. So certainly most of the beneficial effects are probably not related to a diuretic effect. So we do have reasonable data coming from many groups at the moment showing slightly conflicting results, but certainly there is a diuretic effect to some extent. But if we look at the use of diuretics in the trials, and particularly DAPA-HF, there was very little change in diuretics through the trial, and very few people ended up having a reduction in their loop diuretics following initiation of dapagliflozin. There was a 3% more people had a reduction in diuretics with dapagliflozin compared to placebo. So the diuretic effect is not overwhelming. It is there, it's quite subtle, and it lasts a few weeks rather than longer term.
Okay. Mark, do you know, thank you very much for this nice lecture as well. I'm still wondering about the mechanism of SGLT2 and SGLT1. We suppose that only two, but finally, astonishing, I found the HA there is one. So, and also this assumption for Milton-Packer for EMPEROR, there is some speculated mechanism regarding the myocardial genetics. I think you hear about this and you read this Milton-Packer, which cannot be understandable in most of the editors. But do you know exactly what is the mechanism of SGLT2 and 1? Or it's maybe 3, as maybe in the future 3 as well?
Yeah, so first of all, to say the mechanism of action of these drugs has been talked about more than anything else in cardiology over the last 2 years. And Milton Packer himself has written at least 20 different opinion pieces. So the key thing is to think about how much data we really know from humans with heart failure. So at the AHA, we had 2 trials published, which did show cardiac remodeling for the first time. So we had EMPA-tropism and sugar trials, which showed reduction in end-systolic and diastolic volumes. So that's in humans. So we do now have some remodeling data. When we look for other data, we really don't have a lot of other data, to be honest. We've got the diuretic effect trials, and we've got some data to suggest reduction in pulmonary artery pressures. But exactly how that happens, we don't really know. From a point of view of the renal function, we definitely see improved renal function. But again, why that happens, there's lots of hypotheses and theories, but very little data. So there are a few groups who've done mechanistic trials, and we're just starting to look at the data. As I say, we published the remodeling data. We've got renal MRI data, which we're looking at today, actually. And we've got some other, the Danish group have got some very good numbers of patients in trials as well. So there is some data actually about insulin sensitivity as well being improved by the drugs in people with and without diabetes. So I think the answer is we don't know what the mechanism of action is beyond these very small bits of data in humans with heart failure. And we have to try and dig a bit deeper. But frankly, reducing death, reducing heart failure hospitalizations, improving quality of life is the most important thing for patients. And mechanism doesn't really concern people in outpatient clinics, the patients themselves. And we don't really know how beta blockers work or even MRAs. So I don't think in many areas of cardiology we spend too much time thinking of mechanism. We think about stopping people dying and thinking about improving outcomes.
Thank you very much, Dr. Peter. I want to ask about, we have now 2 SGLT2 inhibitors, the EMPA and the DAPA. When you use EMPA and when you use DAPA?
Okay, that's a great question. So the answer to that is that I think the trials from the diabetic trials through the chronic kidney disease trials, through the heart failure trials, the drugs all look pretty similar, to be honest. Apart from articuloclosan in the Virtus trial, didn't seem to have the same benefit as the other trials. So I think you can look at the drugs. They're very similar chemically. I think they really have very similar effects. DAPA-HF did have a mortality benefit, but I think that mostly reflects the patient population and trial design rather than a true difference between the drugs. So I think the message is we want to use these drugs in heart failure. We don't really have to worry about which one particularly. But for me, again, I'm biased because we've been involved in DAPA-HF, and we do have a mortality benefit. But I think EMPA is a great drug as well, so I'm happy if people use either of the drugs as long as they're looking after heart failure patients as well as possible.
It's nearly the same question, but I'll ask it directly. If you have a patient with mild to moderate or say moderate impairment, CKD, would you go for EMPA or would you go for DAPA?
Okay, great question. So technically, DAPA-HF went down to 30. We saw clear benefits down to an EGFR of 30, and EMPEROR-Reduced with empagliflozin was down to 20. So if you're being very strict, then from a heart failure perspective, you can stick by that. But again, we've seen DAPA-CKD in chronic kidney disease populations, going down to 25. So, and we've seen credence with canagliflozin as well. We don't have EMPA-KIDNEY yet, so we're still waiting for the empagliflozin chronic kidney disease trial. So again, I'm confident with both drugs, frankly, down to 30, and probably clinically with both drugs down to an EGFR of 20. for initiation, and I wouldn't criticise anybody for using either of the drugs down to that level.
Thank you, Mark, very much for this lecture, and you have a great 2 lectures today. Thank you very much. I hope to see you in person.